Hello and welcome. Today we're doing a clinical deep dive into one of the most common things you'll see, acute bronchitis. We're going to trace the entire journey, right from the first cough and how we test for it, all the way to specific treatments and what it all means for public health.
So here's our game plan. We'll start with the disease profile itself, then get into identifying the culprit pathogen. From there, we'll cover treatment for adults, then see how things change for kids. We'll wrap up with infection control and a look at potential complications. Let's get started.
All right, Section 1, the disease profile. Before we can treat it, we have to know exactly what we're looking at. So what is the classic presentation of acute bronchitis and who's most at risk?
At its core, acute bronchitis is an inflammation of the bronchial tree. It comes on fast, and here's the key, it's usually self-limiting. The number one symptom, the one that drives patients crazy, is that persistent cough. And it's so important to remember that the vast majority of these cases are viral, which means antibiotics are not the answer. Now, this timeline is absolutely crucial, especially for managing patient expectations. Look at this. Most of the initial complaints, the respiratory stuff, GI symptoms, even conjunctivitis, they're gone within a couple of weeks. But the cough? That's the real kicker. It can hang around for up to 6 weeks. That's long after the virus is gone, all because of lingering bronchial hyperresponsiveness. Of course, not everyone gets the same mild case. For some people, this can get serious. You've got to be on high alert with patients at the extremes of age, so neonates and older adults, and anyone who's immunocompromised. And it's no surprise that things like having COPD, being a smoker, or even just living in crowded conditions can really stock the deck for a more severe infection.
Okay, Section 2, finding the bug. So how do we tell a straightforward viral bronchitis from something bacterial that we actually need to treat? The key is a smart, tiered approach to diagnostics, especially when you're dealing with a potential outbreak.
Think of this as a diagnostic funnel, which is super common when investigating outbreaks in kids. You don't just throw every test at the patient at once. You start with the usual suspects, rapid tests for flu and RSV. If those come back negative, you move to the next tier, looking for things like adenovirus. And only if you're still empty-handed do you bring out the big guns, casting a wide net for those atypical pathogens. And obviously, getting the right diagnosis means getting the right sample. If you suspect an upper respiratory infection, a simple throat or nasopharyngeal swab does the trick. But if you think the infection has moved into the lower respiratory tract, you got to go deeper. We're talking sputum, or even a bronchoalveolar lavage. And for those really high-risk systemic cases, like a suspected epiglottitis, you go for blood cultures to get your answer without messing with the airway.
Section 3, adult treatment protocols. So, let's say you've confirmed it's bacterial. What now? Let's walk through the first-line antibiotic strategies for adults.
This table is basically our playbook, and you can see right away how nuanced this is. If you've got standard H. influenzae, amoxicillin works great. But, and this is a big but, if it's a beta-lactamase producer, you have to switch gears to co-amoxiclav. Then, for the atypicals like mycoplasma or the very serious Legionella, we jump to completely different classes like doxycycline or levofloxacin. The takeaway here is crystal clear. You have to tailor your treatment to the bug. When you think about it, it's pretty wild. A patient's lungs can basically turn into a 5-star hotel for bacteria, offering nonstop room service with a constant supply of purulent sputum. It's a funny way to put it, but it really highlights the challenge we're up against. Okay, Section 4. Now let's talk about our youngest patients, because when it comes to kids, it's a completely different ballgame. You have to be much more cautious.
And this right here is the fundamental difference. In a little one, say under 2 years old with a mild infection, the mantra is watchful waiting. We know so many of these are viral, so we do everything we can to avoid unnecessary antibiotics. This is a huge contrast to the adult approach where once you've confirmed a bacterial cause, you're much more likely to pull the trigger on treatment.
But when a child does have clear as day pneumonia and you make the call to treat, this is the number to burn into your brain. 50 milligrams per kilogram. That's the recommended daily dose for amoxicillin, your first choice oral antibiotic, usually split into 3 doses over 5 days. That kind of precision is just non-negotiable in pediatrics.
All right, Section 5. Let's zoom out. We've talked about the individual patient. But what about the community? This is where infection control and mandatory reporting become the absolute cornerstones of public health. Now, this isn't just about good practice, it's the law. These reporting groups tell us how seriously to take an outbreak. The really scary stuff like SARS is in Group A2. That requires an immediate call to public health. Whooping cough is a B2. Others, like meningococcal disease, are Group C. And then you have some, like chlamydia pneumoniae A, that you only have to report if they cause an outbreak in a place like a nursing home.
So how do we stop the spread? Well, it's a spectrum. It starts with the basics that we should all be doing: cough etiquette, washing your hands. But in a hospital, it gets more serious, like cohorting sick patients together. In a high-risk scenario, like with SARS, we're talking full-on strict isolation and FFP2 masks. We even go as far as giving post-exposure antibiotics to close contacts in some cases to stop the chain of transmission in its tracks.
And that brings us to our final section, complications and review. Let's talk about what can happen after the initial infection is over. Then we'll put all this knowledge together and tackle a couple of clinical cases.
Yeah, just because the initial infection is gone doesn't mean the patient is out of the woods. Acutely, they can develop a nasty secondary bacterial pneumonia, empyema, even meningitis. And for infants, apnea is a huge risk. But there are also chronic, long-term problems. Q fever can lead to endocarditis down the road, and after a Legionella infection, some patients suffer from debilitating fatigue and depression for months, sometimes years.
All right, pop quiz time. Let's apply what we've covered. Here's the scenario. A 4-year-old child comes in with what looks for all the world like pneumonia. Based on everything we've discussed, what's your first-line oral antibiotic? And for how long would you treat?
And the answer is B, amoxicillin, for 5 days. Just like we talked about, it's the go-to for pediatric pneumonia. It hits the most likely bugs, and kids generally tolerate it really well. Okay, let's try a tougher one. Now we have a 68-year-old from a nursing home. So high-risk patient, high-risk environment. The sputum culture comes back, and it's a nasty one. Pseudomonas aeruginosa. What's the right call here?
The correct answer here is C, ceftazidime, for 2 weeks. Pseudomonas is not a bug you mess around with, especially when it's causing pneumonia. You need a heavy hitter with specific anti-pseudomonal activity, like ceftazidime, and you need to treat for a longer duration, at least 2 weeks, to make sure you've truly knocked it out. Which brings us perfectly to our final thought. We've just walked through all the current evidence-based protocols, but these aren't written in stone. With antibiotic resistance becoming a bigger and bigger crisis every single day, the real question is, how are these protocols going to have to change over the next 10 years to keep up? Something to think about. Thanks so much for joining me for this explainer.